quickly. So what I am going to first cover up will be ankle blocks and foot and ankle injections. So typically ankle block is very useful for all those patients who are not fit and who have a lot of medical comorbidities. And the way we foot and ankle surgeons give block and the way anesthesiologists give block is different. Anesthesiologists, they like to create a wheel all around the ankle. But typically a foot and ankle surgeon would block 5 nerves: superficial peroneal nerve, deep peroneal nerve, saphenous nerve, sural nerve, and posterior tibial nerve or a tibial nerve. So I am going to talk on to ankle block, and that would be followed by how to inject into interdigital neuroma, how to inject into ankle, and how to give injection for heel pain. So what is the mix which we use? So if you are giving an ankle block, we use xylocaine or lidocaine, we use sensorcaine, and we do not need to use any steroid into it. When we are using a joint injection, we are using either 1 cc of depomedrol, which is now not available, so you could use triamcinolone, and 4 cc of sensorcaine, because we want to give a long-term relief. And you also use 2 cc of if you are putting an injection into subtalar joint or sinus tarsi. So now let's start with the ankle block. Which are those 5 nerves? Where do they give the supply, and how to block this nerve? So superficial peroneal nerve, if you see, it gives supply to dorsum of the foot, and it is palpable into thin and lean individual. How do we palpate superficial peroneal nerve? You do plantar flexion and inversion of the foot, and the plantar flexion and plantar flexion of the fourth toe. So plantar flexion, inversion of the foot, and plantar flexion of the fourth toe. And look at the dorsal aspect of the foot. You may see superficial peroneal nerve. It is palpable also and visible also. I did show you in my clinical examination. And how do you insert the needle for that? You go from the midline of the tibia and direct your needle laterally towards fibula. So this is where your nerve is, and you will be able to target the nerve, and you create a wheel here. Direct this needle laterally, and maybe 5 cc of subcutaneous injection should be good enough. Maybe sometimes you use 7.5 cc. Then comes your deep peroneal nerve. Now, deep peroneal nerve lies into anterior ankle. The line shows the deep peroneal nerve. It is exactly midway between medial malleolus and lateral malleolus. It is immediately anterior to the ankle joint line. And if you are putting your needle to inject this nerve, to block this nerve, it is important that you should be watchful for not piercing the anterior tibial artery. And the key is to aspirate before injecting, and it innervates the first web space. Now, how do you inject for the deep peroneal nerve? For the deep peroneal nerve, your needle is inserted at the level of ankle joint. It is exactly into the center of the ankle joint, and you go right deep up to the anterior tibia. And once you hit the bone, you pull your needle 1 or 2 millimeter out, and then you aspirate, and then you inject. Sometimes you have to use 5 to 7 cc of injection. Now, saphenous nerve is on the medial side and the anteromedial distal tibia. It is palpable in thin and lean individuals, and you have a saphenous vein accompanying it. And innervation of the saphenous nerve is onto the anteromedial aspect of the ankle and foot. So, how do you block this saphenous nerve? For blocking this saphenous nerve, your needle is placed proximal to the ankle joint, subcutaneously it is directed from lateral to medial. So in lateral to medial, you go right up to the saphenous vein, and then you push in your needle, and 5 to 7 or 10 cc of blocking solution is what you need to require. Then comes your sural nerve. Sural nerve supplies to the posterolateral aspect of the ankle. It is again subcutaneous. It is exactly midway between the anterior border of the tendo Achilles and posterolateral border of the fibula, and again it innervates onto the lateral border of the foot. So how do we block this sural nerve? You put in your needle subcutaneously and begin at the posterior border of the fibula, and from there you go right up to the tendo Achilles, and you pull slightly needle out, and then you use 5 to 10 cc of solution for blocking sural nerve. And then the last nerve which has to be blocked is a tibial. Now this is a very important nerve to be blocked, because you see this nerve this nerve is one which I also block for resistant uh, plantar heel pain, where I do give a block of the posterior tibial nerve, and that gives pain relief for about 3 weeks. So this nerve is at posteromedial part of the ankle. It is deep to the flexor retinaculum, and when you are injecting, there is a risk to have intra-arterial injection to the posterior tibial artery. So you should be watchful. Again, before injecting, always aspirate, and this nerve innervates complete plantar aspect of the foot. Now how do we place the um, needle for injecting this? If chance permits, I'll take a small video of a posterior tibial nerve block, and I'll show you during our course of these sessions. So you go 1 centimeter proximal to medial malleus, you go medial to tendo Achilles, and from medial to tendo Achilles you go right up to the depth where you are going to touch the medial aspect of the tibia, posteromedial aspect of the tibia, and then you pull your syringe or the needle just 2 to 4 millimeter out, and then inject. So you need to inject 15 to 20 cc of the solution. Whenever I am using this block for a plantar heel pain, I take about 2 cc of Kenacort. So 2 ampule of Kenacort, I mean 2 bulbs, and that makes 2 cc. Then I use Xylocaine to the tune of about 6 to 8 ml, and rest Sensorcaine, and sometimes I use saline. I make it 20 cc and inject it to give blockage of the posterior tibial nerve for plantar heel pain cases. Now, interdigital neuroma you want to inject, right? How do you place your needle? You are going into the interspace. So you should be palpating the both the metatarsal and going between the metatarsal. And you palpate the metatarsophalangeal joint, go at the level of the metatarsophalangeal, palpate, or you draw a line or mark with a marker a metatarsophalangeal joint, and go in between two metatarsal about a centimeter proximal to metatarsophalangeal joint. Put in your needle, and this needle should go right from the dorsal web space up to the plantar aspect of your skin. So you put your hand while you are putting your inject with one hand you are putting your syringe and needle down, with the other hand you are palpating at plantar skin. That needle is now touching the plantar skin, and then you withdraw the needle about 3 to 4 millimeter and then inject, and that is what is going to block the interdigital neuroma. So around 5 cc of the mixture. Uh, what I do is I take 1 ml of Kenacort plus 2 ml of Xylocaine plus 2 ml of Sensorcaine. That is what I use. Ankle injection, you could give ankle injection either into anteromedial space or into the anterolateral space. And for that you need to palpate the soft spot of the ankle. On a medial side, it is medial to the tibialis anterior. On a lateral side, it is lateral to the tendon of extensor digitorum longus. But by and large, an anteromedial ankle injection is what is preferred. You put in the needle, go directly down, and then turn your needle towards the posterolateral aspect of the ankle. So you are underneath the important structures in front of the ankle, and then you inject. So that is how you inject for ankle joint. Uh, Plantar heel pain, you use 1 ml of Kenacort, 2 ml of Xylocaine, 2 ml of Sensorcan. This is the mix you use for plantar heel pain. Now this is what is a very very important thing. You must all focus on to this. You need to palpate calcaneus, start from posterior and go on palpating the bone up to anterior aspect where there is sudden give way, and this is the soft spot. So from the bone to the soft spot is what you traverse from posterior to anterior with your finger or thumb, and then you have to inject dorsal to the plantar fascia, you have to inject dorsal to the spur, and you have to inject anterior to calcaneus. So look at this slide. So you don't inject below the fascia. If you inject here, patient would have plantar fat pad atrophy for which there is no treatment. If you inject here, then fascia would definitely rupture. So what you are doing, you are injecting anterior to calcaneus and dorsal to the spur and the fascia. So inject above dorsal to the fascia, anterior to the calcaneus. This is the site where you should be injecting for plantar heel pain. Thank you. So that was about the injectables and blocks which we use. Uh,
Sir, may I ask a question, sir?
please.
Sir, do you routinely use steroid for all the blocks, sir? It is just for all these painful conditions, sir.
No, see ankle block, you don't need to use steroid. You giving an foot and ankle block for the anesthesia. There you
Yeah.
don't use steroid. For interdigital neuroma, you do use steroid. For ankle injection, suppose patient has got ankle arthritis or synovitis of the ankle, and you want if the patient has not progressed to the level that patient requires a surgery, you use a steroid. or or you cannot operate the patient because of comorbidities, there you can use these steroids.
Yeah. Okay, sir.
Sometimes you give diagnostic blocks.
Yeah.
Diagnostic blocks which you like say uh, midfoot arthritis. For midfoot arthritis, it is very, very difficult that sometimes you will find all the midfoot joint having spurs and arthritis. So everything looks like, oh, you have arthritis of so many joints. For that, differential injections under image intensifier guidance or differential injections under ultrasonography guidance is required. For that, you inject only local anesthetic, and for that, you inject only xylocaine, and effect would be for 45-50 minutes, and that is how you did. So not for everything you need to use steroid. You need to use steroid for the cases where you really want to give this block as a treatment. Suppose plantar heel pain, you want to give it as a treatment, you need to use steroid. Interdigital neuroma, you need to use steroid. Otherwise, not at every place you need to use steroid.
Sir, in
Which
case of
steroid
plantar
can I,
heel pain,
yeah, which steroid can I caught or
yeah.
depomedol good? I was quite comfortable with Depomedrol, but I guess Depomedrol is not available in Gujarat. I do not know what is the scenario elsewhere. So then in that case, I am using Triamcinolone.
So whenever you're using the steroid, do you dilute it, or especially in case of a plantar fasciitis,
Yeah,
how
it
much
gets
do you inject?
diluted. Like you are using 5 cc, you're using 5 cc total solution. You're using a steroid plus you're using Xylocaine plus Sensorcaine. So it gets diluted.
Yeah. How much of steroid, sir? Either 1 cc or 2 cc of steroid?
Okay. I did tell you in my presentation. So 1 cc of steroid plus 2 cc of fast acting local anesthetic and 2 cc of long acting, short acting and long acting local anesthetic.
Sure. Thank you, sir.
So is it true in depomedrol patient complains of more pain? I am not sure, but depomedol definitely is a heavy molecule, and ideally speaking, it mentions that it should not be used intrathecally. Our question is not using it intrathecally, but we definitely use it for. Is that available elsewhere? I guess it is not available.
No, not available in MP, sir.
Yeah.
Also, it's
So it
available in our state. Kerala, it is available.
available.
Sir, it is available in some South India states, sir.
Yes, sir.
Here in
It's available.
Telangana, Hyderabad
So
also it is available.
yeah. So for my preference would be Depometrol if it is available.
Yes, sir. It
Uh,
is, it is actually marketed by Neon Labs, sir. The
mhm,
routine anesthetic drugs
mhm.
with a brand name called Primaxo.
Okay, that's a great info. Thank you.
Excuse me, sir. Sir,
Ah,
can I just add something?
hmm,
Sir, from my experience, like we used to do a lot of midfoot and forefoot injections in the United Kingdom for arthritic changes as well. So a lot of patients they never used to agree for the fusions. So we used to give at least after every 3 or 4 months, we used to repeat the steroid injections in the midfoot and forefoot conditions as well. What we used to have found out that it was used to be very painful to give these injections in the midfoot because finding those joints are very difficult even under the image guidance. So
so
there is a consensus of giving short GA to those patients so that we can actually hit the right spot because sometimes it used to be multiple pricks while giving it in the TMTJ joints or intercuniform joints. This is what
so
I saw.
yeah, so the key is to use ultrasound guidance because what happens that there are bridging dorsal osteophytes, so you will not be able to pierce the joint even up under the image guidance. So for all midfoot arthritis, if at all I'm injecting, I have never used anesthesia, but I'll go with the ultrasound guidance. So because ultrasound guidance, you can even go in between the spurs for the needle. If you are going with the image guidance, you have to go from dorsal, but going from the side is quite difficult. But in ultrasound you have a opportunity going to go from the side, go from the top. The problem with this small midfoot joint injections is that whatever you do, injections do spread into the other joints. So whenever you are using this injection, it is sometimes very difficult to really make sure that okay, this is a joint which is giving pain because some part of the injection diffusion or percolation occurs into the other joints. Now there is a question that posterior tibial nerve for plantar fasciitis, what is my indication? It is my secondary conservative modality. So if my conservative modality is for about 4 to 5 months fails, then I use posterior tibial nerve block. How frequently does one repeat injection for plantar fasciitis? So plantar fasciitis, I do not remember that whenever I might have injected in for the plantar fasciitis. No, I usually avoid injecting for plantar fasciitis because literature says that it doesn't make so great sense. It is like a placebo. The effect lasts for a very short time. But if you really wish to do that, maybe after your failure of 6 to 8 weeks of conservative modalities, you could try local steroid injection, and not more than two should be used. That is what is my understanding. But I personally do not use it. So if you do not have any more questions in onto this, uh, we will go and talk on to orthotics and footwear modifications in foot and ankle. Anybody had any question?
Sir, excuse me, sir.
Please go ahead.
Uh, in retrocalcaneal bursitis, he also recommended for injection or
Yes, absolutely. So when you are certain that the disease is into the retrocalcaneal bursa, injection is quite a preferred modality of the treatment because this is mainly due to seronegative arthropathy or rheumatism. So for that, you can go from either medial or from the lateral side. Lateral side, you will have to be watchful for not injuring the sural nerve. could go from the medial side also and inject your local anesthetic plus steroid into retrocalcaneal bursa. So that is a
And
preferred
sir,
method of treatment.
how much chances of tendo Achilles ruptures after injection or something
So when
in
you inject into retrocalcaneal bursa, it doesn't give any tendo-Achilles rupture. But when you
okay.
inject into tendo-Achilles at its insertion, 100% it is going to give the rupture of the tendon. So don't inject at the insertion of tendo-Achilles for Achilles tendinopathy. I am talking of a condition where either a rheumatoid case or a seronegative arthropathy where patient has got pure retrocalcaneal bursa. No problem at all into the tendon, no disease into the tendon. Don't venture uh, in injecting into the tendo Achilles insertion for insertion Achilles tendinopathy. I
Okay.
hope I
Thank you,
have
sir.
made it clear,
Yeah.
and we
Thanks.
will, yeah, and we will also discuss it further when we talk about tendo-Achilles issues. So uh, now I'm going to present three case scenario, and because this group has got so great kind of participation and you people are having very good knowledge into foot and ankle. I am sure that I am going to learn at the end of this fellowship quite a more than what you people are going to learn. So that's a real advantage on my side. So I am coming with this case scenario. These are by and large arbitrary three cases. We all prescribe orthotics, right? So just a guesswork. This is a case one of a female 42 years who has got plantar heel pain from 3 months. She has been prescribed medications plus silicone heel cushion by a doctor. And then this is the kind of scenario. She has pain uh, perfectly subcalcaneal pain, and this is the kind of silicone heel cushion prescribed. And uh, with visit 1, 2, in spite of adding stronger painkillers, visit 3, 4, 5 patient is not improved. And then my question would be why? Now case number 2, male of 39, plantar heel pain of 5 months. Now this time doctor gave medications plus customized heel cushion. So arch molded nicely, molded and plaster cast taken and then customized soft insole. But then, in spite of this and physiotherapy and medications, for 5 good visits, patient was same. And what must be the problem? And then case number 3, female of 13 years. So all patients of the same age group, same duration, pain in heel 4 months. Here doctor recognized it. Oh, this patient has got flat foot. So he gave R support plus silicone heel cushion plus physiotherapy plus medication. This is the kind of R support which was given to that female patient. But at the end of 5 visits, patient was same. So what must have gone wrong? Three similar cases, right? Heel pain of 3 to 6 months. Orthotics footwear modifications given, but they all failed to improve. Now, any guesswork that what must have gone wrong? This is the case one. Any guesswork? Okay. So while we treat the cases and while we give orthotics, we must evaluate patient in a standing position. And this patient on standing had pes plano valgus. And if this is the scenario, you need to correct the mechanics over and above giving an orthotics to give rest to the heel. So this is how the situation of this patient was, and that's why this patient did not improve. Too many toes sign. Okay, so it was a case of plantar heel pain secondary to flat feet with heel valgus. So it required medial arch support, medial heel post plus silicone heel cushion. Only silicone heel cushion will not work in such cases. Yeah, so somebody uh, did not customize our support. Okay. Now coming to next case. So in
Sir,
this case, it was a problem of evaluation by us doctors, that we do not evaluate the patient properly and we just prescribe orthotics. Okay, somebody was asking something, please.
yeah. Sir, I was asking, sir, what do you mean by heel post, sir?
So this talk
One
is
minute.
going to show what is heel post.
Okay, thank you, sir.
So yeah, so whenever we post something additional, extra at the level of heel, it is called post. So post is, you can say it could be a wedge, it could be a layer 2 to 4 layer of some orthotic material, and that is called as a post. It could be in the footwear, it could be in the shoe. I'm going to show you the pictures of the post. So problem of evaluation. Now this was the case number 2, where doctor realized that okay, I'm going to give customized uh, cushioned orthotics, but still this patient failed. Any guess what must have gone wrong? This is what has gone wrong. So there was a cavus foot with varus. So it was a case of plantar heel pain due to cavovarus fit, which required corrective arch support plus addition of a lateral heel wedge or lateral heel post, which was probably the problem of a prescription. So it was a wrong prescription. And now this, I think, because of you all being a very knowledgeable foot and ankle orthopedicians, someone should give me the answer, because this is a real case situation. This lady presented to me and somebody treated her. Somebody noticed that this patient has got flat foot giving heel pain. So this kind of orthotics were advised, but still she was not relieved.
So this
Anybody?
patient, so this patient need an additional medial heel wedge.
Now this patient has no valgus of the heel, just a flat foot, just
Additional
a
of
flat.
silicon hill.
She was given silicone heel over and above this, so which she used to keep additionally.
So was it a
Medial
more
wedge seems to be larger in longer in size
high
than it should
arch?
be.
Maybe she doesn't need any wedge.
No, she has a flat foot, so she required that. So that was a correct evaluation. That was a correct prescription also. So we saw one problem which we make is that of evaluation. The second problem we make is a prescription. So that is also right. Evaluation is also right. Uh, I don't
So
think it
the
is that longer, because if you do a lipstick test, it fits into the area where the arch collapses.
okay.
So this is where what we do, we prescribe orthotics and we never evaluate orthotics, whether the orthotics are proper or not. And look at this. Now, can you guess something? This is my finger and
I
I'm pushing it very hard. I'll run this video.
It is not flexible.
It is very hard. It is very hard. So it was like a pebble underneath the foot. And that's why this patient had increased pain after this. Okay. So that was a problem of evaluation. It in fact required change of the material, and the height of the orthotic was also high. So it was a very hard support which was extra high. So that reduction and the change of material helped this patient. So that was problem of monitoring. So that is how I'm going to talk about how to evaluate, how to prescribe, and how to monitor footwear and orthotic modifications in our routine outdoor. So it really plays a big role in management of foot and ankle ailments. We have to rely on to a good orthotics or footwear modifications to be successful as clinicians. So we have to be perfect in evaluating the patient, correct in prescribing the orthotics, and we should be serially monitoring the orthotics. Now, what are the 6 Chanakya Sutras for evaluation of patient whom you want to give orthotics. Anybody, one by one. What is the most important thing in evaluation? We do it.
Proper clinical
We
examination.
are going to give. Sorry, we are going to do complete thorough clinical examination. But what are those 5-6 points which you would be putting maximum weightage? Yeah. So please go ahead.
Always examine the
Barefoot
patient
observation.
when patient is ambulatory.
No,
So the
one after another. One after
yeah.
another, please.
So the
Yes.
deformity, sir.
So somebody said evaluate patient
Weight
in a
bearing.
weight bearing. That's a fantastic point. All those patients in my tenure, whosoever has been referred to me, they're not getting better and referred to me for the expert opinion. I've always noticed that they've never been examined in a standing position. So standing evaluation is very, very important. So that is one. Somebody said evaluate deformity. Yes, absolutely. You need to evaluate the deformity, and accordingly you need to look whether deformity is fixed, correctable or fixed, rigid, semi-rigid or correctable. Anything else?
Footwear examination.
Yes, you would do footwear examination, which is going to tell you that what kind of footwear this person is using. Okay. Anything
To
else?
assess the functional demand of the patient.
Okay, that's also a great point. But we are talking about evaluation. So the first thing somebody said, make them stand, and most importantly, let them turn around or you turn around the patient. So this is the most commonly missed clinical evaluation is the arch abnormalities. So either planus, cavus, valgus, varus. This is the second important thing. You need to look at the sole of the foot because the pressure symptoms you would be able to see and evaluate when you look at the sole of the foot, where you would see some kind of cone, callosity, and you know that this is the area giving most pressure to this part, and then we need to offload pressure from that particular area, right? Okay. So sole of the foot examination is important. Anybody, which is this case and which is this case?
One is a Lisfranc injury,
Different.
and the other one is a plantar fissure rupture.
Excellent. You don't need me. You don't need me. So
Thank
who
you, sir. Thank you.
answered this? Who answered this?
So I'm Sri Ganesh. I'm
Arey
from
Shri
Kerala.
Ganesh, you need a pat on your back. Great.
Thank you,
But
sir.
this was the answer I wanted from someone. Do check the sensations. Because orthotist is not going to check the sensations. And believe me that they give a very hard orthotic and your patient comes after 2 weeks to you with ulcer. And then whatever bad is being done by orthotics, yeah, it is you who get the blemish because you referred them to a ex orthotist. So you need to check the sensations and you need to mention specifically that please note that this patient is insensate. So that is very, very important. And if such a kind of footwear is given in a neuropathic patient with leprosy, she will have this kind of pressure ulcer. And do not forget tendo Achilles. You must evaluate tendo Achilles tightness and such kind of uh, you know small callosity cone. You just need to do tendo Achilles release and it would heal. Make them walk. That's equally important. So if you make them walk, then only you know where the pressure is coming, where are they putting more pressure, what must be the wrong. So patients who have got problem of the tibialis posterior tendonitis or synovitis or rupture may like to walk on a lateral border, and patients who got lateral ligament injury or lateral ligament insufficiency or lateral insufficiency or cavus, cavovirus, would have a thirst while they walk on a uh, so look at this patient. Now you feel okay, everything is with that. There is some chaos, but and some virus. But then, if the way this guy walks, he walks on a lateral border of the foot, and this patient would need a stronger procedure for correction of the chaos. So make them walk, and this may not be the case where you will go for the orthotics, but you might have to go directly to a surgical procedure. And somebody rightly said you must examine the footwear of the patient. What is the flexibility of the footwear? So that's with regards to a, a clinical evaluation of a patient when you are to prescribe orthotics or a footwear modification. Now, prescription per se. So, what is an ideal footwear modification prescription? So for that, you need to ask three questions. Why am I using orthotic or a footwear modification for a given case? So what is the purpose that I am using this? And then there are six functions of this orthotics or footwear modification. First function is reduction of an impact. So for a plantar fasciitis, you or a plantar heel pain, you want to use a kind of orthotic which reduces the impact over that place. So that's why you're using a silicone heel cushion or a customized heel cushion or this kind of sleeves. The second purpose of the offload of the orthotics is to offload the pressure. And for diabetic ulcers or for a corn or a callus, what you use is a footwear or the orthotics which would offload the pressure, which would take away the pressure. Like in this orthotics, this patient has got ulcer here. This patient has got ulcer underneath the first MTP joint. So this patient has got a metatarsal pad for offloading the transverse metatarsal arch. The third first function is to correct the deformity. Mind you, orthotics can only correct a flexible deformity. If you try to correct a rigid deformity with the orthotics, then your patient would come back with a lot of pain. So, stage 2 and stage 1 flat foot, where the deformity is flexible, you are using a corrective orthotics. But stage 3 and 4, where deformity is rigid, you have to use the accommodative orthotics. Otherwise, patient's pain would increase. So you need to know that what is the purpose that you are using this orthotics. You can even mention in your prescription to the orthotics that boss, I want to correct the deformity. The fourth is the accommodation of the deformity. So this is a kind of orthotics which you're going to use for stage 3 and 4, where you just want to accommodate the deformity. You don't want to correct it because it's a rigid deformity. And orthotics are also used to limit or restrict excessive motion of the joint. Suppose hallux joint has got arthritis. You want to reduce the movement of the hallux. So you can give a carbon fiber plate, or you can give a Morton extension like this. Or you have a midfoot arthritis. You may put in a carbon fiber plate or a midfoot arch support to limit or restrict the excessive motion. Or for a bad arthritis of the hind foot, you may give ankle foot orthosis to limit the excessive motion and give rest to the part. And you could also use orthotics to compensate for restriction of the motion. Suppose you've done ankle fusion or you've done tibio-talo-calcaneal fusion, you give such a rocker. This is the example of the rocker in the foot, in the footwear. So this guy mimics like he's walking and he's using a normal foot. So these are the six important functions of the orthotics or footwear modification. And whenever you prescribe, you write down that what is the purpose that you are using. Why is that you want this orthotics? The question two which you need to ask yourself is what type of orthotics or footwear modification you are desiring for a particular case. And this depends on what kind of orthotics you want to use for a particular deformity. Orthotics are of three types: soft devices, semi-rigid devices, or rigid devices. Soft devices are really soft, will not give any pressure. Semi-rigid devices are like in between, and rigid devices are going to be rigidly correcting the deformity. So you need to know that for this particular case, what kind of orthotics I want to give. Now, soft devices, their function is to just accommodate. If patient has got neurovascular geopathy, if this patient has got some kind of a uh, skin graft with a prominent bone, or if patient has got heel pain, if patient has got toe deformity, what all you use would be a soft device which would accommodate this deformity, and all over the counter products, they are soft devices. So you should know that what is the condition your patient is suffering and what you want to prescribe. Then there are semi-rigid devices. Semi-rigid devices either are for the support or for the correction or for both support as well as correction. They are easily modifiable. Compliance could be 50-50, and all customized products which we make, these are semi-rigid device. Suppose you want a customized arch support. Suppose you want a customized correction of a foot drop. You are using semi-rigid devices which corrects as well as supports. And then rigid devices are for correction of flexible deformity. But mind you, this rigid devices has a very rigid material. There could be issues of the skin. There could be issues like cons, callus, ulcer. And when patient has got lack of sensation, you have to be very, very much watchful using rigid devices. And compliance could also be a problem. So like for a soft device, the material which is used is plastazort, Eliplast, or EVA. EVA is the material which is being widely used, and these soft devices are used for the diabetic foot, rheumatoid foot, cavus foot correction, used for all over the counter devices for toe deformities, heel pain are with this soft material. Semi-rigid devices are used by 3/8 inch polypropylene or subortholate, like spots injuries, sometimes for a heel pain, mild to moderate pronation because of the flat foot, you are using semi-rigid device. But rigid devices are 1/4 inch polypropylene. Be very, very watchful when you are using it. You could use it for ankle instability, tarsal coalitions, flat foot, for correcting the deformity. Now, orthotics also has another classification. This classification is either you have a prefabricated orthotics or you have a custom-made orthotics. Prefabricated, yes, they are already made and then you just buy over the counter and use it. Custom-made is when your own foot mold is taken, your patient's plaster mold is taken and it is made customized for that particular patient. The customized could be again accommodative and could be functional. Functional could be for flexible, accommodative could be a rigid one. So these are prefabricated forefoot pad, arch pad, heel pad, which is available and you could use it. Custom molded, like total contact surface is casted, and the concept is to distribute weight to the largest possible surface area and thereby to reduce the pressure at one particular specific area. And then you can select various materials. I don't want to go into details of all this thing, but accommodative is a total contact form which disperses the plantar pressure. Functional one is to control the forces during subtalar fusion, like subtalar and mid-tarsal joint problems. These are all example of custom molded. Accommodative is what we use for diabetic foot, but the functional is what we use for flat foot, and this is the rigid UCBL. Now, I am going to spend some time later on to UCBL. But before that, okay, where is the slide of UCBL gone? Okay, now UCBL is University California Orthotics, which I am using very, very rampantly, I would say, for a flat foot where I require a good correction. So UCBL is a firm to hard material which corrects heel, gripping it from the back. It corrects the valgus of the heel and also corrects the medial arch support. Going forward, we will see the examples of UCBL. And the last part is how to make an ideal or rational footwear modification or an orthotic prescription. So this is the kind of model prescription I wanted to share with you. You write down the name of the patient, age of the patient, diagnosis, sensations, whether sensations are not or there, very important. And you write down about the function of the orthotics, what you desire orthotics to do, or the purpose of this footwear modification. You want it to support, want it to offload, want it to accommodate deformity, you want to correct the deformity, you want to restrict the movements, you want to compensate for the joint movement. And then you write down whether you want a soft material, semi-rigid material, rigid material. You may draw the diagram of the foot and show orthotists that this is the place where I want a modification. So the next page or the page behind have this kind of foot diagram where you can draw that this is the area you want to offload. So this is what would be an ideal orthotic prescription. Now I'm going to show you some examples of commonly utilized orthotics for a clinical condition. So for a first metatarsal joint arthritis, you use Morton's extension for first metatarsal phalangeal joint arthritis. For a cystoid pathologies and tough toe, use this kind of an orthotics. And for forefoot MTB joint lesion you want to accommodate, you can use this are the various designs for first MTB pathologies. For the toe deformities, in an early stage, you can use toe sleeves, corrective toe sleeves for uh, various deformity correction, or a toe pads for correcting the hammer and uh, uh, mallet toes in an early stage. They work only in the early stage when they are non-operable. In the rigidity kind of a situation where you have a rigid deformity, this will not work. Hallux valgus, you have this uh, toe spacer, you have a hallux night splint, which can be prescribed for hallux valgus. Flat foot, the aim is to support diseased tibialis posterior tendon and to prevent the rupture of tendon when you are talking about stage 1, where this kind of flexible soft devices, arch support here, child support, arch support which can be worn like this are used. In a stage 2, you want your aim is to correct the flexible deformity and also to prevent progressing this flexible deformity into a rigid deformity. And that is where you use UCBL. Sometimes you use supramalleolar orthosis, SMO. UCBL is made out of a rigid material, usually plastic, that is molded over a replica of the foot, which is created by casting the foot. It does not work well with chappals or sandals. You have to ask patient to use a shoe which is of a larger size. And this is how the corrective cast in a non-weight bearing position is taken, and then it is like this. You create a UCBL. This is obviously not the UCBL, some other picture. Flat foot stage 3, your aim is not to correct the rigid deformity, but you want to accommodate deformity in a footwear. So for that, you use a customized brace or ankle foot orthosis. Heel pain, you want to give cushion to the heel and you want to stretch the tight heel cord. This is how the various orthotics you use. Achilles tendon issues, you want to, your goal is to minimize stresses on the tendon. So you want to stabilize foot into plantigrade position. So heel posting with at least 3 mm heel lift is what you advocate. When you want to minimize subtalar rotational forces, again you want to reduce varus or valgus, then you have to have a deep heel cup with heel posting. So semi-rigid heel posting Deep heel cup plus heel post of 3 height is what you use for Achilles tendinopathy. And goal again is to minimize stresses on the tendon. These are the various examples of the orthotics being used. For a Charcot foot, you use Charcot restraining orthotic walker, which is a molded plastic bivalve bivalve. It helps to heal the ulcers and fractures. It is not a long term. You can win it to a molded plastic inside. Now, talking about the shoe modifications, somebody asked me what do you mean by the post. So now the when you put something inside the shoe, something you stick inside the shoe, that is called as a post. This is the heel cushion. This is the arch support. This is the metatarsal pad in a shoe kept. And this is the posting. It is 1/8 inch small wedge added under either the medial or the lateral edge inside the shoe. You could also add it outside the shoe. So lateral posting is for the flexible varus foot, or you want to put your ankle into slight eversion for healing of the lateral ligaments, you go in for the lateral heel post. For a cavus foot, you go in for lateral heel post. For a planus foot, you put in 1/4 inch medial heel post. These are heel post example. Valgus heel, you have a medial post. Varus heel, you have a lateral post. Then some external modification which are outside the shoe. Medial heel wedge, lateral heel wedge, Thomas heel, reverse Thomas heel, and heel flares for the instability. These are all outside the footwear. Practically speaking, they are the same, but they are outside the footwear. You have a medial sole wedge for a pronated forefoot. You have a lateral sole wedge for a varus footwear. You have a rocker bottom foot for where you want to compensate for the loss of motion. You have a metatarsal bar for metatarsal cases. And for a toe deformities, you have,
Excuse me, sir.
yeah, please.
Sir, the metatarsal bar should be outside the shoe or should be a part of the insoles only?
So ideally, I mean, I like to put it inside, but you could also put it outside.
Thank you.
See, all those modifications which are inside the shoe are better because they are more closer to the axis of the deformity. All modifications which are outside the shoe are a secondary preference, and than the primary preference.
Sir, when the inside shoe supports on the post, as you said, they are given, of what material you give it? Is it Plastazot, EVA,
Yeah,
or it's
Plastazot, EVA, yeah, Plastazot, EVA, this material would work. And
these
by and large, you preferred something which is inside,
microcellular
something which is,
rubbers or polymers? Do we use them? MCR or MCPs?
uh, I'm losing connectivity.
MCR or MCPs?
Yeah,
Microcellular rubbers or
yeah,
microcellular polymers?
yeah, that can also be used. That can be also used. Yeah.
I mean, your practice, you use those in your clinic only, means you see the
No,
measurement and your
no,
person, and your,
no. There is an orthotist who is trained by me. So he has
okay,
his own workshop, and my
okay,
patients go to him and get things done.
okay. So all those testing and all those things you are not doing in your own clinic or your setup, where
No,
we need to compare the
once he
report.
comes back with this footwear modification or orthotics, then I monitor it. We are
So
coming to that. We are coming to that. The last part is monitoring.
can you
But
show some photos of your patients where the posts are given, how they are adhesed or how they are pasted, whether they are kept inside the sole or they are pasted on the sole of the shoe?
no, they are stick inside the insole,
Okay.
over the insole.
Over the
So
insole, they are
there are two ways. Either they are stick over the insole, or uh, the insole is customized with that kind of elevation.
Okay, and how much thickness of the plastisode material is used? Is it 13 mm or 10 mm or 8 mm? What thickness you recommend for these patients?
No, have I, I have not gone to that detail.
Actually, sir, I am working on this for a long time and I am frustrated because I'm not getting the enough material or literature for that. So I just ask if you are having some solution for this, that what kind of the closed rubber or the or closed cells or the open cell plastisode, what kind of plastisode should be used?
Yeah, that's really going into very great depth, and I think is uh, maybe you could take a small
Okay,
talk.
I'm searching a lot of material. If I get something, I will share on the group. If I get some
Please,
answer for this.
please, that would be helpful to everybody.
Okay.
And then rocker is like it rocks the foot from the heel strike to toe off without bending the foot or the toe. And this is the rocker which we have in our chairs. So it can offload the forefoot, it can offload the hind foot, it will improve the gait, and it would offload the plantar pressure. So there are various rockers for various conditions. Now this is the one thing which is being used quite commonly in our practice. So there could be a very mild rocker, but this is important. Heel to toe walker when you need less of the ankle motion. So if there is an ankle fusion, subtalar fusion, tibiotalo-calcaneal fusion, this is the kind of rocker which is very, very commonly used. Even you have a calcaneal ulcer, you ask your orthotist to make a rocker which goes from heel to toe, and patient would be able to have a swift movement using this footwear. Then sometimes there is a rocker only to offload the toe. There could be metatarsal head rocker like that, and there could be a negative heel when you have when you want to reduce the heel, which into the when you want to really offload the forefoot, you use a negative heel, and that is commonly for the chronic forefoot overload cases or when you have a very heavy callus or plantar ulcers. For practical purposes, out of this six type of the rock, and there is a last is the case with the double rocker. When you have a midfoot pathology or midfoot Charcot, you use the double rocker. Practically speaking, in my practice, I am using three commonest type of the rockers. This is the most commonly prescribed rocker in my practice. Must be my 80% of rocker prescription would be for this ankle fusion, subtalar fusion, TTC fusion, hindfoot Charcot, calcaneal ulcers, any hindfoot pathologies. This is the kind of rocker which is being used. So even once patient starts walking in an ankle fusion, TTC fusion, you prescribe this rocker, he will have as if he is walking normally. This is what is the feeling this rocker is going to give. Or another rocker which I use is for the cases of midfoot Charcot where there you have a two rocker and midfoot gets overloaded. And very rarely for forefoot pathologies you can use a forefoot rocker. But the use of the rocker is quite common for as a footwear modification. Use of insoles orthotics is quite common as posted inside the footwear. These are the things which are posted outside the footwear. And the last part of this talk is how would you monitor a footwear modification. Now this is very important on our part that we monitor whether this modification or this orthotics is working. If it is not working, do we want to go one step up? If it is working, do we want to go one step down? If this is not working, do we want to resort on to surgical offloading? So this is what you need to monitor. And how do you do that? So when patient comes to you for the first visit with an orthotics prescription which you have done, you look at the quality of the material. So what you had advised is what this guy has done or not. Whether it is a soft material, firm material, hard material. So this was the case I showed that very hard material. Then you look at the position of the support or position of offloading, whether it is at a precise location or it is proximal to where you wanted, or it is distal, or it is medial, or it is lateral. And for that even you could do a lipstick test or some kind of a paint or something you do, and then you see where you wanted to offload. Is it that the offloading which is kept is proximal to the place where you wanted to offload, or it is distal, or it is medial, or it is lateral. And you look at the fit of the shoe when you have prescribed this shoe. So look at this. Herein, when patient is standing onto this orthotics is quite longer. And where you want to offload, it is not offloading. Either patient should be using it with the heel here, then only it will work. Otherwise, if patient is using with the toes here, this is not going to work. This is quite a long orthotics. And then you also look at the pressure effect or impingement or lack of support if that is happening. Now, this patient had a pressure by the orthotics which is given is small uh, pressure impact has given a callus, and now patient is going to develop the ulcer. So that is what you look at the first visit. And then you ask patient to stand, walk, and look at the level of the comfort this patient is having. So this was the one orthotics with which this patient presented in my clinic. And you look, I took the picture to just show you that look at the way these orthotics are put in. Now this guy has a valgus heel. The heel is almost out. The footwear is quite long. Heel is into the valgus. I don't think that the medial arch support or the heel post or anything which is really acting as a worker. So this would not be working for this patient. In a subsequent visit, is that orthotic or footwear modification impinging the patient? Are there any secondary skin lesions or pressure changes? If that is the case, you need to alter it. Then the second thing, you see whether this has started working or not. If it is working, if it is not working, if it is getting deformed. If it is not working, if it is getting deformed, that means you need to go into one step up. So what I do for a flat foot, I start with a simple medial arch support. If I feel that is not working, I go to a stage higher where I give a customized insole which corrects the heel valgus as well as medial arch support. If that is not working, then I'll go on to the University of California uh, orthotics, which is a firm orthotics which would control the heel and thereby it will control the foot. If that is not working, then I need to go to supramalleolar orthosis, and then if that is not working, I might have to go to ankle foot orthotics. Now, if the orthotics or the footwear modification has served its purpose, you may think of downgrading it to give more comfort to your patient. So SMO to UCBL is what you can think. And this is what is most important. Standing x-rays with orthotics to evaluate its efficacy. This is one thing which I have been doing quite often in my practice. So look at this. This was Crow, Sarcot restraining orthotics walker which this patient was using, and in this A for a crow, look the way talus is in a plantarflex direction, and this Charcot foot is no longer being held by this. This requires surgery. So unless you take this kind of a standing x-ray through the orthotics with the footwear on or with the orthotics and footwear on, you will not come to know whether it is working or not. So some sad and important fact, orthotics and footwear modifications cannot correct a rigid deformity. There are so many patients you would be seeing with a corrective orthotics in a rigid deformity, they just impinge then correct. And it will not work for whole life. Most often than not, they are to fail. For certain deformities like hallux valgus, orthotics do not work well. this case is move and progress to surgery. When footwear modification or orthotics fails to work, surgery has to take over. And this is a very bold, dogmatic looking statement I always make, that the orthotists and prosthetists are highly constipated people. Like physicians, they would never let the patients go. So instead of patient not responding, in spite of patient not responding, they will continue with the orthotics. So it will be you as a surgeon who will need to decide that no, time has come that this patient requires surgery, then change of footwear. Now this was a 28 years old male who had a neuropathic non-healing ulcer in an operated case of meningomyelus. This was being treated from 12 years by, by orthotists. They were giving various kind of orthotics in spite of this seeing that this is not working. So it was like heel was into the valgus with arthritis of the ankle and subtalar joint. And this is how, when I take the foot scan, this is how the lateral border was getting overloaded. And then I treated it with corrective ankle and subtalar fusion. Those days that nail was not available. And then in this was at the end of 6 weeks, and this was at the end of 3 months, that the 12 years of non-healing ulcer, it healed. But orthotists were not ready to leave this patient.
So how do you take that foot scan?
Yeah, we are, that's in the next talk we'll discuss that. So it is orthopedic surgeon's wisdom which should prevail, that yes, this patient is not responding. Either I have to upgrade or move to a next step of footwear modification, or I have to go for the surgery. So that was for orthotics and footwear
Excuse me, sir.
modification. Please share photos of 6 types of rockers. Okay, I'll post these photos in the group in
Excuse me,
in
sir.
WhatsApp. Right? Okay.
What we have generally seen is that the people, the orthotics which are usually available in the smaller cities, they are not that educated or they cannot understand our prescription very well. A lot of times we ask them to make something custom made and they give the prefabricated ones because they are not, either they have not read about it. So can we as a group make a list of the orthotic guys who are actually doing this thing in a better way, which can help our patients?
You see, you will have to have figure out someone who can do a medium kind of a job for your some kind of cases. He can serve the purpose, but you might have to look to someone who is nearby to your town or your city, in a bigger city, who makes it properly. So for certain cases you will have to send your cases to the most experienced person, and then you can also intervene and train that person, put your uh, foot down for certain kind of orthotics. You can tell him that, look boss, this is not working, you will have to do it this way. But unless you know it, that what kind of material you want, what kind of rigidity of the material you want, whether you want to correct the deformity or want to accommodate the deformity, unless you know that, you will not be able to really take control of the orthotist. Unless you know that, how are you going to evaluate the efficacy of a particular footwear modification? You're not going to be able to tell to your patient that, look, this is enough, now we need a surgery.
So which brands you use in the prefabricated ones, like all the Flamingo and all those brands are
No,
available basically.
I,
So
I
it
really
is
do not.
just
I really do not go for any brand. I just prescribe for custom. I mean, you want a silicone heel cushion or you want a toe spacer, something like, they go and whatever is available, they do it. I don't opt for any brand, but yes, I uh, I like to go for customized orthotics more often than the prefabricated one. But at the same time, I tell you that there was a study done. I think there were 2 or 3 studies done, that whether the custom molded orthotics is better or over the counter is better. But the study results showed that no, both are same. It doesn't really matter whether you give over-the-counter product or you go for the custom made. But somewhere or other, I have found that the custom made in my practice, in my hands, is a better one. So when I really want a good correction, then I like to go for customized uh, orthotics and footwear modification.
Your orthotic sits in your hospital or he is outside the hospital? You just give
No, he's
prescription for.
outside the hospital. He's outside the hospital. But uh, when we started our foot and ankle center, uh, he used to be there for an hour during the OPD time. So that makes the life of patient easy. So if you are starting or if you are in a your general orthopedic patient, if you want to create your niche towards becoming a foot and ankle surgeon, which is the next talk, you can have one orthotist in your OPD during 1 or 2 days where you are having a dedicated foot and ankle OPD. You can call him. So for initial few years, the orthotist whom we trained to become a foot and ankle orthotist used to be there in our OPD and used to take the tips. I agree, even if they are qualified, they really do not have this clear cut understanding and they go on their own way. So we have to guide them. Which insole
Hmm.
you prescribe for multiple cons? No, see, cons or callosities, they are because of pressure. So you need to understand that where the pressure is coming. And if you really want to make your patient free of the pain because of this, you have to offload pressure surgically. But if the case of multiple con is there, then you prescribe a modification of the footwear in such a manner that you have a very soft silicone insole. So it is a complete prefabricated silicone insole which is fixed into the shoe, which gives a quite cushioned walking area. So that is what we prescribe. So do we have any question or confusion for orthotics and footwear modification? This is one area which I think we are not taught in our residency days, and we come directly into the practice and then we start doing prescribing it. And sometimes some of
Excuse
our
me, sir.
orthopedic doctors, they have fallen in the catch of the orthotist. Yeah, please, Ganesh, go ahead.
Excuse me, sir. This
Yeah.
excuse me for this question, sir. This may not be truly related to orthotics. In one slide, you showed that there is a heel support for tender Achilles pathology. So, in that context, is the high heel chapels of or high heel footwear of the females advantages for tender Achilles pathology?
So for posterior heel pain case, uh, if you have slum heel lift, it works. But then there are studies which has shown that if you give a heel lift for long time, their tendo Achilles gets contracted. And then gaining the natural tone of the tendo Achilles or the length of the tendo Achilles becomes very, very difficult. So what I practice in my practice is for tendo Achilles tendinopathy, incisal tendinopathy. I would give a small heel wedge about 1.5 centimeter, and then slowly I'll ask my patient to come down to the normal footwear. Because if it is given for a longer period of time, uh, heel lift would give rise to contracture of the tendo Achilles. So I use it very sparingly, and I'm very very much cautious when I'm using a heel lift for plantar for posterior heel pain.
Thank you, sir. One more doubt. What is the role of night splints in plantar fasciitis or the heel pain?
Okay, so we are jumping from one topic to other topic, but when your patient complains of pain on in the during the first step in the morning, right? So why is that this pain happening during night? Because of the natural tendency of the foot to go into plantar flexion, the plantar fascia during the night gets contracted, and that is the reason that these patients, they have first step, morning step painful. So all those patients of mine who have got heel pain and they have a morning stiffness or the first step in the morning is very painful, I prescribe them night splint which maintains ankle into 0 to 5 degree of the dorsiflex. So it could be a posterior one or it could be even anterior one. Are you able to see my hands? It could even be
Yes,
anterior
sir.
one. So it could catch hold of the foot and the tibia just with an anterior kind of night splint, or it could be a posterior.
Sir,
So
also the
yeah,
discussion is actually a more needed one. And is it possible at the end of this fellowship, we can actually visit and see the orthotic work? Because surgeries are little easy to understand for the orthopedic surgeon, but orthotics is something which we have never done in our residency or even in our practice also.
I agree.
So is it possible that we actually see the orthotics, how they are prescribed, how they are
Yeah,
made?
yeah. So see, at my center, there are multiple fellowships going on. So I do 10 days of a structured fellowship every year. And in this fellowship, it also has a session of 3 hours at the orthotist place. So all those fellows who are coming are sent to uh, orthotist workshop, and there they practically show that how they take the mold, what are various materials, how they use it, and all these things. So also there is a session with a physiotherapist of mine. So they go to 2 hours, 2.5 hours to a physiotherapist. So there is also a session with my radiologist. So they go there and learn about use of role of ultrasound. I mean ultrasonography in foot and ankle, and my radiologist only takes a session onto MRI in foot and ankle. So that is possible if you join for this kind of a fellowship. So yeah, there are two more questions. T8 diagnosis with calcium different pathology. When do you surgically intervene? Please explain it on the next session. ठीक है. When we talk about Suranjan, Dr. Suranjan, when we'll talk about tendoachilles pathologies, we will definitely discuss this point. This point would automatically come in play. Okay, now this is a conglomeration of a talk at Celine Parekh's Indo-US foot and ankle course, to which we have also added a course for physiotherapist, a day's course for physio. In that course, uh, whatever talks I'm taking, this is a conglomeration of a talk which is partly for physiotherapists but also importantly for orthopedic surgeons, and that is why I wanted you to tell me whether you want to know about this or I just want to skip it. But you all wanted this talk, so it's a small talk, but part of it you would find for physiotherapist also, so excuse me for that. uh, this is very important for a physiotherapist and for us also. We have to clear a patient for physiotherapy and we have to mention weight bearing status. So, unless we do that, physiotherapists are so smart, or rather over smart or over wise, I'll put it this way, that they start weight bearing on their own. And then I have had an experience of physiotherapists who said, इसमें डॉक्टर को पता नहीं चले, this is my domain, I have to decide when you have to walk. And then see, the walking pattern, walking status for every patient is different. For an operator Charcot patient, you don't allow weight bearing for 6 months, though you see that all these joints which you bridge are united. And for some other patient or normal patient, by 6 weeks, 8 weeks, you may start partial weight bearing. So weight bearing status has to be clearly defined whenever we are sending our patient to the physiotherapist. Even if you feel that this physiotherapist would not overstep, you need to mention that. And then use of an assistive device is also important, that whether you want patient to use a stick or a walker, that is also important. And use of foot orthotics. All my midfoot fusions, all my Charcot cases, all my flat foot reconstruction, they all get a medial arch support for 6 to 9 months, even sometimes beyond that. So you have to write down that okay, patient is allowed to walk assisted partial weight bearing with walker, but with the use of orthotics. So unless you mention that, your physiotherapist is going to misfire. And then you have range of motion exercise, you have strengthening exercise, you have balance and proprioception training. Now it is this balance and proprioception which plays very important role in foot and ankle physiotherapy. Balance and proprioception is something which is different than elsewhere. Okay, so general rehab principles, you have an acute phase, you have a subacute phase, and then you start to increase the resistance through the available range, and then you can add complexities into that. Then you progress to the higher ranges of motion, then you start strengthening. In the last part of the physiotherapy, the last phase is activity specific exercise. Like if the patient is a sportsman, he has to go back to all sporting activities. If the patient is a, a heavy laborer, he has to go back to his activities of daily living. Now, these are some 10 important facts of foot and ankle physiotherapy, and this is where foot and ankle physiotherapy differs vis-a-vis physiotherapy elsewhere in the body. Now, more than 50% of foot and ankle conditions can be very successfully managed with conservative modalities like plantar fasciitis, like ankle instability, tendoachilles tendinopathy. 6 months, 9 months, if my patient is not improving with conservative modalities for tendoachilles tendinopathy, then only I am going to operate. Ankle instabilities, by the way, next Saturday will be date will be 12th. So on 12th, we will be having a session of live surgeries where we can interact to and fro. In live surgeries would be from 7 a.m. to 10:30. Now I'm going to demonstrate you insertional Achilles tendinopathy surgery. Now I'm going to demonstrate you posterior impingement of the ankle together with subtalar arthritis. I'm going to do posterior ankle impingement excision and subtalar fusion. So these two surgeries we'll be demonstrating on 12th. And you all know eccentric exercise. This is eccentric tendoachilles exercise where you are rising yourself on the heel, on the toes, and then slowly lifting the one limb, and then from up to down you're going down, and this gives eccentric contractions of tendoachilles. And this is a very important kind of an exercise for uh, insertional and non-insertional Achilles tendinopathy. Now, many times in foot and ankle, you go for prehab, surgery, and rehab. So sometimes you have a malunion, non-union, deformity. You may like to send your patient for mobilization exercises, for some range and strength exercise. Then you take surgery, and then again you send him for rehabilitation. Sometimes it makes life easy. Rehabilitation, post-op rehab becomes quicker. There are physiotherapists who now have a gait lab in the bigger cities, and they also have foot scan. So this is how the horizons of physiotherapy has expanded. Even There are newer modalities added into the armamentarium of the physiotherapist, and that is shockwave and ultrasound guided procedures. They also do ultrasound guidance. Now, for the foot and ankle physiotherapy, like shoulder physiotherapy, in a shoulder physiotherapy, we start with the core strengthening. And the core in the shoulder, we say that is the shoulder girdle and back. So in foot and ankle, lower back, glutei and gastrocolius, these three are the cores. And we have to work very hard onto these core when we start foot and ankle physiotherapy. So you have a gastrocnemius stretch, you have a soleus stretch, and you have to work onto the core strengthening exercises for ankle and foot. Typically, yeah, in last to last session, I think somebody was asking about the plaster for lateral ankle sprain. No plaster. It is early mobilization and rehab, which is as a change concept. For ligament injury, you don't immobilize. You just give a mediolateral brace and mobilize this patient fast. So ankle sprain, you start early rehab, initially weight bearing, range of motion exercise, maybe swimming pool exercise, stretching of gastrocnemius, soleus, followed by proprioception, strengthening range of motion, and lastly, activity specific rehabilitation. Balancing and proprioceptions, they rule over range of motion and strengthening. If you talk about exercises elsewhere in the body, it is getting the range of the motion for a joint and strengthening the muscles. But for foot and ankle, over and above this, you need balancing and proprioception more so with the ligament injuries and tendon problems, because foot and ankle has function of locomotion. So uh, towards the end of the physiotherapy, you go for occupational therapy. So that is activity specific functional rehabilitation. So for foot and ankle, you have to turn to the occupational therapy at the end of the physiotherapy session. So I tell my patient that your 85% of the job would be done by physiotherapist, but your 15% job would be done by you when you start doing your activity specific rehabilitation, or when your physiotherapist teaches you that how best you can do your activity and how you go back to the activities of daily living. And weight bearing status differs from elsewhere in the body, like diabetic ankle fracture, Charcot, you give weight bearing for a prolonged time. You are not allowing your patient to weight bear. But for forefoot surgery, you are allowing weight bearing and asking patient to walk on the heel. So this is how in foot and ankle weight bearing status differs. One has to be watchful for that. And contraindication to foot and ankle physiotherapy are grossly unstable foot and ankle, active infection, peripheral vascular disease, and some kind of malignancy. Now there are various modalities which we prescribe. It could be cryotherapy, where for swelling, edema, you're using it. When there are impaired sensation or circulatory disorders or open wound or hypersensitivity to cold, you should not be using cryotherapy. Contrast bath, when you want to contract and dilate the tissue, but the contraindication is malignancy. Ultrasound is high frequency sound waves which are transferred to deep into the tissue, which causes vibrations, creates gentle heat. It promotes increase into the circulation, reduces spasm of the muscle, decreases inflammation, and promotes healing. It could be a pulsed one or continuous one. So pulse one is superficial one, continuous one goes right deep, and contraindication is a fracture, pacemaker inside, or malignancy. Then electrical stimulation in form of TENS or interferential IFC. It is working for post-surgical pain, sprains, neuralgia, diabetic neuropathy. It works. And then you have iontophoresis, negative and positive ions. This is what works into tendinitis and bursitis. Now conditions versus physiotherapy which you prescribe. Ankle sprain, I already mentioned it. Ankle sprain for a grade 3, again the same, but you have to work very hard onto proprioception. That is very, very important. Unstable ankle, you need to stretch gastrosoleus. You need to train patients for proprioception, which plays very important role. And then strengthening range of motion and activity-specific rehabilitation or activities of daily living. Achilles tendon, you need to rule out rheumatological disorders. You need to rule out Hegland or biomechanical abnormality. And then if there is a malalignment, you have to address malalignment, and then you have to manage the load. Initially, it could be isometric heavy loading exercises. Acute reactive tendon issues would respond best to isometric exercises, and degenerative tendon problems responds to eccentric exercise. And this is how tendinosis exercises goes in: isometric exercise, eccentric exercise, concentric exercise. Oh, these are high-end physiotherapy. But this is the example of eccentric uh, exercise. For a medial sided ankle issues, you teach patient isotonic calf exercises and this isolated tibialis posterior loading. For a lateral side of ankle, you have to strengthen your peroneal either with a tube or a TheraBand, and proprioception exercises would be very, very important. Plantar fasciitis, you need to stretch gastrocnemius, stretch soleus, stretch plantar fascia, teach them proprioception and strengthening, and then activity specific rehabilitation. So this in nutshell uh, are the kind of physiotherapy aspect which we take care in our foot and ankle practice. So I hope are there any questions on to this, or you understood everything, or everything has gone above?
Excuse me, sir.
Yeah, yeah.
Sir, do you have any specific protocols for your post-op patients or for your conservative managements for the physiotherapist to understand?
Mm, not essentially, but because they work with me from so long, they know that this is how it has to go. Say, I sometimes chart out everything that at the end of a week, this is what you have to do. At the end of 2 weeks, this is what you have to do. And I continuously call my patients and look forward to whether the physiotherapy is acting or not, whether physiotherapy is going into right direction or not. And that is what helps me in monitoring the progress of the patient. But not that specific that you have formulated a chart and you give to your patient that you go to the physiotherapy based and do this much. Not really. But one could do that. One could do that. I feel that every patient's problem is different and is not falling into the same sad pattern. So sometimes you have to, you know, tailor your physiotherapy and your orthotics both accordingly. Now, uh, very, very rarely you have a cavus put together with, I mean, very, very rarely you have a flat foot with a medial sided deltoid injury and lateral sided ankle injury. So, in such cases, when you have a flat foot, again, foot is going into valgus, so lateral ankle injury should not bother this patient much because there is a compensatory, there is already a valgus which is itself a caveat or which itself help into healing of the ankle sprain. So in such cases, if you have given a orthotics, you have to discontinue with the orthotics, at least lateral heel, at least medial heel post you should be removing. Or if your physiotherapy for flat foot is running in such a manner that you want to strengthen the medial structures, you may have to halt your physiotherapy and you will have to strengthen your peroneal. So I feel that it is not that by and large it is a set pattern, but not for all the patients. So I don't like to give a pre-formed prescription to a physiotherapist that go ahead with this thing. You getting my point?
Yes, sir. Understood. Thank you, sir.
Yeah. So I mean, you have a plano-valgus foot with a lateral
Mhm.
ligament injury. So instead of patient going ahead and doing a tibialis posterior strengthening exercise, herein patient would should be doing peroneal strengthening exercise. So that is what is the difference.
Thank you, sir.
Okay, setting up of it, this is a very quick small talk. Setting up of a foot and ankle practice. I do not know how many of you want to really become a foot and ankle surgeon. But for those who really want to start foot and ankle practice, uh, these are some guidelines, and the roadmap is that you establish a foot and ankle center of excellence, and then you also go ahead with patient education, you do social obligation activity, research, and then you can expand into your foot and ankle center of excellence. So how to establish a clinic uh, for foot and ankle services? So you need to have you working onto building, then what kind of an infrastructure you want, what kind of instrument equipment, what should be the manpower, and what should be the services you would be given. These are the 5 points into which we are going to discuss. Now, for having a foot and ankle clinic, you could have second floor, third floor with a good lift, any such area would be okay. And you need around 500 to 600 square feet space, where in a building you would need a consulting and a waiting room, a 15 by 15 consulting room with an examination couch of the low height, and there has to be a walking space inside your consulting room because you want to uh, examine your patient in a walking position. And then you also need a dressing space which could be of 12 by 10 and a table with a low height, and you need a digital radiography and a radiography view box in a dressing room. And then you must have the facility of getting weight bearing x-rays. I did discuss it when we talk about the radiology. And then for your investigations, you should have what is called as foot lab. That is what is the name I have given. And it's a area of 15 by 20 square feet where you have a table with a low height, uh, and then you have a walking space. And the kind of equipment you have in your foot lab is monofilament to test the vibratory sense, to test the pressure sense, and to diagnose neuropathy. You can have this instrument called biothiometer, which measures the vibratory sense at various points over foot and ankle. This is the uh, biothiometer where a vibratory sense at various points is noted. As I mentioned, earliest sense to go in diabetic foot is vibratory sense, and biothiometer is an important instrument or equipment helping you to diagnose that. You can have a vascular Doppler, either a handheld or this kind of a Doppler with an attachment to the ECG machine, and you can get this kind of graph. And this is the crude instrument to measure. It's a crude way of measuring the foot pressure. Uh, this is called Harris mat, and then you uh, take this kind of ink and put it over the plantar aspect of the foot and ask patient to stand and take this print, and you know whether the patient has got a cavus foot or a planus foot or a pressure area is at heel or at toe. But this foot scan is a sophisticated instrument through which over which patient walks, and then it takes a pressure measurement of 10,000 points over your foot and ankle, and the measurements are transferred to the laptop through a software, and then you have uh, various points and the gait pattern and how much pressure is generated at various part of the gait, at heel strike, at toe off, at foot flat, and what is the kind of pressure is what is depicted by foot scan. Now this is at the heel strike, this kind of pressure zone at toe off. Now normally this green pressure zone is absolutely normal. If the pressure is more, slightly more, it would be depicted as yellow color. But if the pressure is very high, then it would be shown as a red zone. So look at this. Now this is the foot scan of an Indian cricketer, Indian fast bowler. Now he uh, was having problem of reduction into the speed after bowling 5 to 6 overs, and this is where he was putting more pressure on the heel and was also on the merge of developing calcaneal stress fracture. And so you advise him to change his style to land onto the forefoot, then onto the heel, and then he increases his speed and he is off his problem. This foot scan is of a diabetic patient who is very likely to develop a heel ulcer, a very difficult kind of ulcer to treat. So high pressure zone, various foot pressure and point analysis is being done by this foot scan. And then somebody was asking, how did you take the foot scan? And this is the same patient. We're asking him to walk and stand over the foot plate and you depict the pressure area. So he has more pressure onto the lateral border of the foot, and this is what you need to surgically offload. When you have somebody was also asking that whether your orthotist comes to your clinic. If he comes to your clinic during your outdoor, it's fantastic because you could have a center of orthotics and footwear together with your foot and ankle center of excellence. And then you also should have center for foot and ankle physiotherapy where you can have balance board, TheraBand, very effective modality and very useful modality of treatment in foot and ankle is TheraBand, balance board, proprioception is very important. And then some specialized equipment, radio frequency ablation, which is used for tendinitis, fasciitis, bursitis, and this is the again the fast bowler of Indian cricket team with distal plantar fasciitis, and I am doing the radio frequency ablation of this sportsman. And then you have extracorporeal shockwave therapy. Initially, I was using that of the kidney lithotripter, which is very cumbersome, but now you have foot and ankle specific shockwave machines which are being utilized for plantar fasciitis, tendoachilles tendinopathy, and other conditions. You need to have motorized mini E-pen and the saw and burr drive, and you should have arthroscopy available to your armamentarium, tendoscopy for with 2.7 mm scope. You do scopy of the tendon, some dedicated foot and ankle instruments, that is what you require. And then the very important instruments are lamina spreader and interment distractor and some key reduction forceps and devices. Manpower, you need receptionist, technician to do foot lab, dressings and radiology all together. A part-time counselor come medical social worker would work well. And then team of the medics and paramedics would comprise of physiotherapist, orthotist and prosthetist, a vascular surgeon, general surgeon, plastic surgeon and diabetologist or a general physician. And then special clinics which you should be running are adult foot and ankle clinic, pediatric foot and ankle clinic, diabetic foot and ankle clinic, sports foot and ankle clinic, and then you need to really brand and market this because there is a huge ignorance amongst the medics as well as paramedics as well as patients about foot and ankle ailments and its solutions. So you could have your website where you're talking to mass, you could have a website where you're talking to medicos, you should have your logo and punchline, and then you should be doing great amount of patient educational activity uh, by means of what we used to do. We call it a foot school, and we also should be educating surgeons. And then some project of social obligation when you are becoming a foot and ankle surgeon, you can definitely take We run two projects, diabetics. For diabetics, we run a project called Save the Foot. For leprosy cases, we run the project We Walk. So Save the Foot for the diabetics, we go and talk to the diabetic patient. For the uh, leprosy patient, there is Asia's largest leprosy colony, 9 kilometers away from my city, where I work as honorary foot and ankle surgeon and work for the leprosy neuropathic patients with this kind of ulcers and this with kind of deformities and with this kind of footwear has now been trained to develop indigenous footwear in this kind of formulated with footwear with the machineries, and then these people are now these patients are up and up on their feet with corrected footwear, and thereby they heal their ulcers. Research, training, publication should also be the part of your foot and ankle center. So let me wish you all the best if you are thinking to set your foot and ankle center of excellence. So that's all for all the talks. Yeah, that's a great question by Dr. Pratap. How much would it be to cost set of foot and clinic like you? So it all depends, but I guess something between 6 to 8 lakhs. Now, the certain things you may not start with. You need not buy foot scan. Foot scan can cost you 4 lakhs to 8 lakhs. So you need not buy foot scan to begin with. So you can gradually go on investing, and if you want to start your center, maybe you could start it with 3 4 lakhs of investment. Most important is to make people aware about the services which are available into area of foot and ankle orthopedics. So any questions, or we'll quickly take up the cases. Any, I think no questions there. Okay. Before we talk about the cases, let me show you a video of posteromedial approach for talus. So I did tell you that next time I'll show you the. So is this screen seen?
Yes, sir.
Okay. So posteromedial approach for talus, or a posteromedial variety of fracture of talus. So how many of you are exposed to this approach?
No, sir.
Yeah. So nobody has ever done posteromedial approach?
No, sir. Medial malleolus osteotomy middle.
Yeah. So how do you decide that you would need a medial malleolar osteotomy for a kind of posteromedial variety or medial variety of talus fracture, or you would need posteromedial approach? It is in a sagittal section or sagittal CT scan, you draw a line from anterior and posterior aspect of the tibia, and anterior and posterior surface of medial malleus. You draw a line, vertical line. So all those fractures which are posterior to the posterior medial malleolar line would require posteromedial approach. One which are posterior plus medial, falling between the lines of the medial malleolus, would need probably medial malleolus osteotomy. You got this point?
Yes, sir.
Yeah. So not that every posteromedial variety of talar injuries you need a posteromedial, medial malleolar osteotomy. Okay. You see, these short videos, I have not called a professional videographer, but my assistants, they take this video. So then it is like a sort of learning experience for us. Hello, I am going to demonstrate you a short video of posteromedial approach for a posteromedial talus fracture. But let me show you the case. This young patient of 32 years old had injury because of the road traffic accident on September, in the September, last week of September, and this were the x-rays, and these x-rays were passed as normal, and patient was given a crepe bandage. Persisted with the pain and went to the another orthopedic surgeon who took the x-ray, and this was the x-ray, and he sensed something going wrong here. So this was in the month of October that this x-ray was taken. He gave a bologna slab for 2-3 weeks, but patient did not improve, and went to the another orthopedic surgeon who got the x-rays, and this were the x-rays which showed medial condyle of talus fracture. So what investigation this surgeon should have done at this? So the question is that the every 3 weeks this patient got x-ray and went to 1, 2, 3 orthopedic surgeon. At this juncture, when you notice something going wrong here, something going wrong on a medial side of talus and posteromedial side of talus, which investigation would you ask for?
CT, sir.
CT.
It is okay. So I think we have all ignited people here. But then, look, this guy got, the orthopedic surgeon got MRI. This juncture. So surgeon thought that he will get an MRI, and he got an MRI. I would have definitely got a CT scan, and MRI showed something going wrong here, some pieces, some loose pieces, and this were bigger fragments on the medial side. And looking at this MRI, that surgeon also got a few images of CT scan, which, if you can see here, also shows comminuted fracture of the medial side of the talus. So what would you do at this juncture? Anybody? Two and a
Upon
half
detection, grafting, fixation.
Okay. Okay. So, okay. We'll move forward. Few days back, it showed this kind of picture, but the most vital picture which it showed was that of hyperemia into the lateral ligament of ankle, and lateral ligament of ankle was probably not seen because this patient was asked to walk and he was getting repetitive inversion injuries. He was unstable. So he thought that now there is a lateral ligament injury together with a healed posteromedial variety of talus. And if you see the coronal images, in the coronal CT scan which was taken on 20th of January, it showed some hyperemia and signals into the deltoid ligament. So he also thought that this patient, over and above having a healed posteromedial variety of talus fracture, has got deltoid injury. So it was a... So first orthopedic surgeon just gave crepe bandage. Second orthopedic surgeon gave a 3 weeks plaster. The third orthopedic surgeon gave plaster and got MRI and gave plaster. And the last orthopedic surgeon at the end of 4.5 to 5 months got this MRI. And then he said that Dr. Shah, here is a patient who has got a lateral ligament injury plus deltoid injury. So you need to address both the ligaments. Now, any guess that why this patient had lateral ligament injury and why this patient has medial ligament hyperemia in MRI?
Probably he had dislocated the ankle at the time of the injury, which has actually caused this fracture, and subsequently the ankle might have got reduced.
Uh,
Sir, he was
Lateral thrust maybe. Constant
Because
lateral
of
thrust.
instability.
exactly. So this guy had a medial sided instability while the fracture had not healed. So he used to invert, right? And the medial sided hyperemia was
because of the
because
repeated.
there was an injury. There was an injury on the medial side. And that hyperemia takes long time to subside, provided when patient is not asked to take rest, patient goes on walking with this malunited medial sided fracture, you also have hyperemia there. So that's why when this patient was referred to me, it was referred with a note that you have to reconstruct medial ligament, you have to reconstruct lateral ligament, and uh, you have to just do supervised neglect for the uh, healed fracture. Okay, so we move forward, and this time that this patient was referred to me, and surgeon wanted me to do reconstruction of the lateral ligament, reconstruction of the deltoid ligament, and he said that fracture is already healed. So when this patient came to us, we got his standing x-ray because he was walking but with the pain. So this is how the standing x-ray showed main piece healed with the talus, but then there are some loose pieces which are around the deltoid ligament and around the medial side of the ankle. And I got CT scan, and these are the CT images, and it shows that now as you're coming from posterior to anterior, this is the sustentaculum tali. Now there are loose pieces, but if you see the subtalar joint by and large seems, even if you see here, subtalar joint by and large seems okay. There are other CT images of significance. Again, this is a malunited posteromedial part of talus, and yeah, this semi-coronal views are very important view. They are showing this loose fragment. This is a big loose fragment. The main fragment seems to have united, and subtalar joint is clear. And these are some small pieces as you go more anteriorly. So, having shown this case, so the question is that I know that my assistant is learning to take the video. Some pictures should have been shown more closely. But how would you treat this patient? Anybody?
So now complaint is
Corrective
only instability.
Yes.
debridement of the area with the corrective osteotomy and fixation, and then
Which
correcting any ligamentous
osteotomy?
laxity which is there.
Which osteotomy?
So there is a malunited fracture of the talus. If it is malunited, as long as you keep the malunion, nothing else is going to work. And the loose fragments over there is causing irritation of the ligamentous complex. So debridement of the area, removing the loose complex, doing an osteotomy to correct that images are not shown. Probably that's what you're referring to. And doing a corrective osteo to correct the alignment, and then correcting residual ligament laxity if we have any. That would be my approach.
Yeah. So I partly agree to it in the form that there was no mechanical laxity of any ligament, right? It was the functional instability. There was no mechanical instability, and the loose fragments were definitely irritating the ligamentous structure on a medial side. Otherwise, the subtalar joint was okay. So I feel, and then there was no depression at the subtalar joint where you would have required some kind of corrective osteotomy. So my approach was to just go in, debride, and remove all the loose pieces, and then give him a rest to the part in form of non-weight bearing and a mediolateral ankle stirrup support. And if the ligaments go on giving persisting problem, then to go in and address them. So this is what is the approach I have taken, because the major fragment uh, has united and the joint was absolutely okay. I did not think of any osteotomy or anything which would be required for that. Few days back, it showed this kind of picture. So that seems part of that anterior. Having shown pieces as you go more anteriorly. So, having shown the arch is normal, so what should be the treatment? So once you think over it, we'll go ahead with this video and we'll pause this video for some time. Okay, so Dr. Neerav and Dr. Viral, I am their shadow, they are working with me. So they corrected me that, sir, this patient was what a cavus, and it has a significance. Once you see this video, we'll discuss what is the significance of cavus in this patient. Anyway, so posteromedial approach for talus or the posterior process or posteromedial part of talus, I like to do in a prone position. So patient is prone and I have put in a bump so that I should be easily able to manipulate the foot, and image intensifier comes from the lateral side. Now, if you can come closer and show, I have marked tendo Achilles, I have marked calcaneus, and this is what I have marked are vessels, and this is the medial malleolus. So our incision, this approach is between tendo Achilles and flexor hallucis longus, and if you see, here is tibialis posterior, then it is flexor digitorum longus, and then neurovascular, and behind neurovascular is FHL. In fact, in this approach, flexor hallucis longus protects the neurovascular. So you start marking it just by the side of the tendo Achilles, and as you come down, it would be advisable to go more medially. So this approach is like this. Sometimes you may require to distract, and then you put in a distractor between tibia and calcaneus, and you distract with a Hintermann distractor. Sometimes you also need to, I like to sometimes put in a step-in or a K-wire which would retract flexor hallucis longus here and tendo Achilles here. The key or the tip is to be very, very near. What is the significance of cavus in this patient? So we have cut the skin and subcutaneous tissue, and this is how the picture looks. So once you open the skin and subcutaneous tissue, you should be going very, very close to tendo Achilles, and then when you dissect deep to the tendo Achilles, or just by the side of tendo Achilles, there is an aponeurosis. Now this is the aponeurosis or the sheath under which you will find flexor hallucis longus. it is very important to remember that you should be starting from the top and going to down, because as you go down, structures they come closer. So you should, if you want to dissect or you want to find out the flexor hallucis longus, you should be starting from the top and going down. Now, when I cut the sheath of FHL, all sheath or such structures, when I cut, I like to mark it with a marking pen, so that later on, when I want to take the sutures, this gives me a lead to go ahead and repair this. So what I have done, I have opened up the tendoachilles is on one side. I am opening this aponeurosis, and then when I open it, I'll be seeing the flashy muscle fiber of flexor hallucis longus. So this is a dissection which goes from below up, and once you find out that yes, you've gone to the FHL muscle belly, then you trace it down up to the tendon, and that would make your life easy. When you are when you want to identify FHL, you also simultaneously move the great toe, and you will come to know, okay, this is the FHL. So whenever you want to find out flexor hallucis longus, even flexor hallucis longus transfer for tendoachilles problem, you should start proximally, because proximally you have a muscle, and distally this tendon goes very close to the neurovascular. So what I am holding and what Dr. Neerav is holding is the fibro-osseous sheath of the flexor hallucis longus, and I am going to cut it sharply and into the center to make sure that we open the FHL tendon. And FHL tendon do have some connection with the ankle joint, and when you open it, you may find some fluid coming out. Now when you are opening this up, it is obligatory for you to resuture it. Now I am going down and I am opening up the fibro-osseous sheath of flexor hallucis longus, and I am going right down, and again I am going to mark with the marking pen this sheath, because we are going to close the sheath, otherwise flexor hallucis longus may not be into the marking pen. Please, it has to be going back. So whenever you want to, okay, so what I want to show you is that this time we have taken flexor hallucis longus laterally, and to retract it continuously I have put in a wire to retract the FHL, and this was the place from where I removed this loose fragment. So this was a loose fragment from the groove of FHL, and then there were some loose fragments here which also I removed. Now I am going to put in a bone wax into this area and close it. Okay. Okay. So what we have done, we have removed this loose fragment and a small intra-articular fragment here, and this is how this fragments they are seen. And then when you do closer, you have to close the sheath of FHL so that FHL doesn't snap, and you also need to close the aponeurosis over the flexor hallucis longus. So that was a posteromedial approach. You go either between tendoachilles and FHA. That is the most common scenario. Very rarely you take FHL together with tendoachilles, and then you go cautiously beneath the vessel over the bone and do your job. So that was as per you people's suggestion that you take small videos when you are doing this surgery, That's what we did. Uh, the last quick portion of today's session is our case discussion. Quickly,
Can I ask you a question, sir?
please, please, please.
What do you close the sheath with, the FHL sheath and the pneurosys? What do you close it with?
Vicryl. Sheath
Vicryl.
with 1O Vicryl,
Hmm.
and I mean sheath, all this thing with 1O Vicryl.
One of it. And how do you sterilize your marking pen? ETO.
It, yeah, it, I mean what we
E-
get is pre-sterile, and then if you
hmm.
want to reuse, you can do ETO, but it dries
ETO.
up.
Okay.
It's, you cannot reuse it.
That's why I'm asking. What do you use it?
Yeah,
I
it
mean,
cannot be reused.
because I
Yeah.
don't somehow don't. I'm not able to trust the pre-sterile ones. So
No,
what
these
do you
are
do for that?
pre-sterile. Yeah, they come with the pre-sterile flexible foot rule and this.
Yeah.
So the first case which I
Okay, sir.
posted, I wanted you to know about the significance of injury of the first ray. The first ray and the fifth ray are peripheral rays, and their restoration of their length and rotation is very important. And that's why somebody just sent me a short case story and a video of just that much portion of the CT scan and asked my opinion that whether I should fix it or I should give a plaster. And then you all were perfectly apt onto that. Your answer was that we should fix it, and majority of you came up saying that we should be fixing it with a, plate which is spanning plate. Okay, this second case, which was a missed uh, second tarso-metatarsal metatarso-cuneiform dislocation with Lisprang. Uh, so the question on the horizon was whether to do naviculo-cuneiform fusion or to leave that alone. So yes, all of you came up with that. Yes, you have to do the fusion of TMT tarso-metatarsal joint. But what about the naviculo-cuneiform joint? And then the answer could be that if the cartilage of naviculo-cuneiform joint, the second cuneiform is dislocated dorsally, for pretty long time it remained dislocated. If the cartilage is degenerated or very loose, then obviously naviculo-cuneiform fusion would also be required. If it is not so, you can just leave it. You can reduce it and leave it like that. You may say that you may like to fuse first, second, third tarsometatarsal, intertarsal, and naviculo-cuneiform joint. Then also you are right. If you say that I would look at the status of the cartilage and decide on table, then also you are right. But what I wanted to convey was the cartilage status is equally important for you when you are going ahead with this midfoot surgery. And sometimes you do get good cartilage and you may like to save the joint. Yeah. In foot and ankle, you have to define a joint, whether it is an essential joint or it is a non-essential joint. Essential joints requires to be salvaged as far as possible. Ankle is an essential joint. Talonavicular is an essential joint. Your fourth and fifth metatarsocubar joints are essential joints, and your first, second, third naviculo-cuneiform, first, second, third tarsometatarsal joint, calcaneocubar joint are non-essential joint, and you can go ahead and fuse them. The case 3 was of equinocabovarus deformity. I wanted you people to come up with the ladder of correction of equinocabovarus deformity, but unfortunately that was not uh, written by many. Yes, you could do Ilizarov surgery if your patient is ready. We were talking about the open surgery. So for an open surgery, the ladder of equinocabovarus or equinovarus correction is you start with you start with open tendoachilles lengthening, where the Z lengthening, the inferior arm of the Z is medial to reduce the medial pull. And then if doesn't correct the equinus deformity, you can go ahead with posterior capsulotomy of the ankle. If still it doesn't come, you can go ahead with posterior capsulotomy of subtalar joint. If still it doesn't correct the deformity, you may add a plantar fasciotomy to it. Then if still it doesn't correct the deformity, you go in for uh, partial talectomy and lamellum diffusion. If that also fails to correct the deformity, you go in and do total talectomy and calcaneotibial fusion. So this is the ladder of equinovarus deformity correction. And sometimes you will feel surprised that okay, you just could get out with posterior release or just could get out with posterior and medial release. This surgeon who sent me this case, I had advised him to go for, and I told him that looking to your deformity and the duration of this deformity and rigidity of this deformity, you would need a tibio-calcaneal fusion. But to his surprise, to my surprise, he could correct the deformity completely and he could get out by doing a tibio-talocalcaneal fusion and added a talonavicular fusion. So he could get out by doing pantalar fusion without any shortening. So that was the case number 3. Case number 4, obviously it was a diabetic Charcot and it requires a long segment fusion. So it was a dislocation of the first and second. So you should be doing first TMT, first naviculo-cuneiform fusion, second tarsometatarsal and second naviculo-cuneiform fusion. You may need to add a intertarsal fusion also because in Charcot you need longer combination, stronger fusions. You need to span the normal joints. The last case was for I think that was again sent to me by some of the person from some of the doctor from our participants, and the patient had a base second and third metatarsal fracture. So rightly many of you said that we will have a spanning plate. Some of you, if you wish to pass in KYS, you could get out with KYS, but then you have to have a special configuration of KYS. I would prefer a spanning plate for that case. And then Dr. Hari Prakash sir's case, it was less frank. Somebody suggested fusion. Uh, I am not sure that every Lisfranc should be fused. It is the status of the cartilage intraoperatively which would take a call. If it is a subtle Lisfranc, if it is a Lisfranc which you receive at the end of few more weeks, and it is a pure ligamentous injury, you may think of going ahead with the primary fusion. But otherwise, today's tune is like go in, look at the status of cartilage and try to reconstruct, then to fuse. And then Dr. Anoop's case, CKD with ankle swelling, and he had sent the pictures also. I feel that, I want to know whether this patient is diabetic or not because he is a chronic renal, CKD. I mean, is he having a diabetes, Dr. Anup? Are you with us? But when it was like ankle swelling, we might have to go in for the uh, hematological investigations, and then if not, we might have to go for the biopsy of the synovium of the ankle. But mind you, if it is a diabetes, you should also suspect conversion into Charcot. So this was about the cases we discussed. I don't think we have Dr. Anup to give us more details of this case.
Uh, Excuse me, sir.
Yeah. Go ahead.
Thing about Dr. Nikhil?
So what plates do you use there for fusion of joints, or if it is planning, if you are planning to span the joint, what is the configuration of plate? And another thing, in the first case, it was the intra-articular base of first metatarsal fracture. So is it essential to bridge the joint, or you can get away without bridging the joint by just fixing it with a T plate dorsally?
So both great questions. So let me talk to the, let me answer the last question first. So intra-articular fracture fragment, and the fragment was plantar warts, is very difficult to really fix from plantar aspect to the dorsal aspect. Hmm. And so if you just give traction, if you put in a temporary distractor, you get the length of the first ray, and then you can put in a spanning plate, bridging plate, which is not uh, damaging the articular cartilage. So that is the most ideal thing. But you cannot, I mean, you're good, you could also try to fix up a lag screw from a posterior medial fragment, dead posterior fragment to the dorsal fragment. The problem is that you can even with your screw, it can also irritate the tendon, and fixing it from dead posterior to dorsal is difficult. So the most ideal thing would be to gain the length and just put in a spanning plate. Now, answering the first question, that if you are using a plate, I like to use a plantar plate on a first ray and dorsal plate, which is like a square in design, which would fix both cuneiform, both metatarsals through one plate. So this is what I like to use. The first thing for me would be to put in a screw from the second metatarsal, which goes to the first cuneiform, and then I put in the one plate, which is a square plate for second and third, and a lateral or a medial or a plantar plate for first ray. Well, someone has, yeah, Anup's case, do MRI possibility of marrow infarct? Yes, it needs to be ruled out in, yeah, that's a very, very common thing which you find in CKD cases. So you need to rule out marrow pathology also. And then there was some case posted by somebody where he has used K wires for the second ray also. So I would not agree to that. You have to stabilize intercuneiform instability. In this case, you have to put in a plate, spanning plate in the second ray, in the third ray, fourth and fifth, yes, by the K wires, and first by again a spanning plate. So that was not put in that case. So that should have been the story.
Sir, what about if the skin condition is not good enough to put the plate?
Yeah, so in all those cases, you just span. You span uh, both the sides, medial as well as lateral side. When you're doing spanning, you manually reduce a dislocated metatarsal. You can put in a temporary K wire, a thin K wire, and with only one or two attempts, not that every time you pass and come out. So that would be temporary fixation. Wait for 2-3 weeks when the skin wrinkles comes in, and then you operate.
Okay, sir. Thank you.
And if it is like situation which is beyond 4 to 6 weeks,
Yeah.
you will have to go for fusion.
Okay. Sir, in my case,
No,
sorry.
please.
Sir,
Please go.
Dr. Hari Prakash, sir, in my case, which I have sent you, sir, that is actually done by us by around before 3 months. We have nailed the tibia and that lisfranc. Because of the bad skin condition, we have opened it on only on the medial side because the second ray, which got dislocated, it was not getting reduced, and there was some soft tissue. It was hinging in between. So we opened it up medially, and we reduced both the first and second ray through that medial incision, and we have put K wires for the first and also second and second, and from cross K wire from the first to the first uniform, first ray, like we put the list rank screw. And then we have fixed the fourth and fifth also with the K wires. And the skin condition is actually very bad, and it's been almost 3 months now, but the patient is still on K wires. So my question to you now is, when you fix it with K wires, and how long do you keep it? Here the good thing was the arch was maintained well. The foot arch was maintained well.
See, ligaments take long time to heal. All these patients, they have bad ligament injury. So ligaments take 9 months, 12 months to heal. We all know this. And you cannot keep K wires for more than 6 to 8 weeks. So that would be temporary fixation. Wait for 2-3 weeks. Then you operate.
Yes.
So ultimately, some or other time you will have to go in and do a fusion once the skin condition improves. The most important thing is when we put in a spanning fixator, we need to reduce the dislocations. That's very important. If
Okay.
you don't reduce the dislocation, your skin condition will not improve at all. And
Yes, sir.
then once you're forced to keep KY for pretty long time, the option for you is a fusion. And first, second, and third ray, they are non-essential joints. They are rigid. You want to make them rigid, so go ahead and do fusion. It's not a problem. The fourth and fifth ray are require soft fixation. There you put in KYs for 4 to 6 weeks. And even if they are labile, even if they are little unstable, it doesn't matter. We want dorsiflexion, plantarflexion of metatarsocuboid joint for mobility.
Both. Okay. Thank you, sir.
So I am going to show you a, video of one of the live surgery for Lisfranc fusion. So I don't know how many of you attended Bombay Orthopedic Society's Advanced Foot and Ankle course. There, I think I have recording of 2 surgeries, and one of that surgery is Lisfranc fusion. So I will show you that when we talk about the Lisfranc. Spanning plates normally are to be removed at the end of 6 to 9 months.
Sir, for the fifth case, sir, you said about spanning plates, sir. So we fix the second metatarsal to the intermediate cuneiform, sir, and third metatarsal to the lateral cuneiform.
Yes, definitely, because all these rays are unstable. The first you convert all cuneiforms into stability by intercuneiform screw fixation, and then you start with second, fix second first, then fix first, and then third, and then all this thing would be in form of bridging plate.
Yes, sir. That case, the patient in the Lisfranc joint looks stable, sir. The fifth one, where the base of second and third metatarsal fracture was there.
Yeah, so if they are stable, you just fix it with a spanning plate, bridging plate. You're not violating the cartilage. So it's good. You remove it at the end of 6 months.
Thank you.
Regarding the topic of postomedial approach, so you told to take CT first in such a trivial looking injury with a normal looking X-ray. Under what circumstances should we order a CT scan? It is on the first visit or second visit, and why not combine CT and MRI scan as actually done in this? So now this is a great question, you see. Now when you have lot of swelling and your X-ray, lot of swelling, lot of tenderness, patient is not able to bear weight, and you have a history of a very bad vehicular trauma, and your X-ray is normal, or you're not able to judge anything on the X-ray. This is the time you must take a CT scan, because it was because of lack of high index of suspicion in that case. Two orthopedic surgeons they missed talus fracture. The third one get got MRI. Ideal would be a combi scan. If it is like it has taken some time, then combi scan. So for me, if I want to rule out a bony injury, CT scan is a must. For me, if I want to rule out a ligamentous injury, soft tissue injury, then MRI is there. And when it is a late presenting case where you have a problem of the soft tissue as well as bone, combi scan would be good.
So what was the lengthening plan for the case 3? They just did the ankle fusion. It must have resulted in shortening. And whether the shortening was assessed, whether it was tibial or suprapatellar shortening, and did they plan for lengthening of that case?
You're talking about case of equinovarus deformity?
Yeah.
Yeah. So, could you repeat your question? I did not get it.
So after the fusion, there must be a shortening because it was a compensatory endoachilles
Right.
shortening to
Right.
gain the length. When they had corrected or they have got the plantigrade planar foot after the fusion, there must be significant shortening. So what was the plan to correct the shortening? Or that was sufficient enough to correct in the orthotics?
So you see, these patients, you give an option to them that whether you want an Elizarov surgery or you want an acute correction. An acute correction will give you shortening, and then either you should be prepared to accept the shortening or you should be prepared to go in later on for lengthening through the Elizarov. Right? And
So if
if you
you
want Elizarov, then you may not get the shortening. So that is an advantage of the Elizarov. But then there are
if
some disadvantages also. So it is patient choice which prevails in accepting the kind of surgery they really want. So
if you would
these
have been
patients,
operating this case and patient wants the proper length,
yeah, then you
then what
can
would
provide.
you
So then I think the most ideal is Elizarov, where you not only correct the deformity, you also
Gradual correction.
yeah. So you gradually correct the deformity. If there's an issue of length, you can also do it.
Yeah.
Otherwise, the
but what will
patient
be your what will
most
be your
often the
corticotomy site for tibial
upper
transport? It will be upper
upper
tibia, lower tibia.
upper tibia.
Considering the
Obviously
bad
upper tibia.
bone status on the X-ray which is seen, still you will go there only because that part of the bone looks like little deformed and not a good quality of bone in this case.
Yeah, he
Yeah,
had some.
especially in this case because bone quality is not good there.
Yeah, so he had some kind of injury. In fact, I am not much aware about this case, but you know that every day, all those 6 or 8 cases which I answer to various orthopedic surgeons, I just pick up some good case for generating the discussion. Uh, I advise that surgeon to speak to the patient and discuss whether you want Ilizarov or you want acute shortening, acute correction, or you want a chronic gradual correction. And then if you want an acute correction, you should be prepared for shortening. So that was explained to the patient. Patient opted for acute correction. In fact, patient was explained that you would require talectomy. But fortunately, just few days back, that surgeon sent me the post-op X-rays where he could correct everything and did a ankle and tibiotalar fusion added with a talonavicular fusion.
In case 4, which turned out to be the Charcot foot, would you recommend the bilateral MRI to see if the changes are happening in the opposite limb or if there is a more fragmentation or the Charcot is affecting some other part of the limb as well? Or we will just fix as what the X-ray picture is showing us?
So you're talking about Charcot deformity?
Case 4, which we
Hmm?
had discussed, that turned out, yeah, I'm talking about the case 4, which turned out to be the Charcot and a long segment fusion has to be done. But do you
Hmm.
recommend MRI to go ahead before operating on this case and comparison on the opposite side if the same pathology is started on the opposite side also?
No. I will not recommend MRI for that patient, nor I'll recommend comparative MRI for that patient. Only thing where I am to put in screws into talus, only place where I am going to span the talonavicular joint or I am going to fuse subtalar joint in a Charcot patient, I will 100% get MRI of hind foot, more so that of talus, because I have burnt my shoulders in 2 Charcot cases where you're doing a hind foot Charcot fusion, you're doing talonavicular fusion, you're doing subtalar fusion, all your screws are getting jugged into the talus, and talus itself is having hyperemia and is soft, and on table 2 of my cases talus broke. So then I was not prepared. In one case, I was not prepared for going ahead with an ankle fusion. It was like TTC fusion then. So all those cases where your whole fixation in Charcot is relied onto talus, the the structure of the talus, involvement of the talus is there or not, I almost always get MRI. Otherwise, for a midfoot Charcot, I don't require MRI. I don't feel that there is need for MRI. The
Okay.
need
So would
for
that
weight bearing X-rays is very important. You see, if patient is coming to you with an Charcot with an X-ray which is just 15 days old, you should not settle down with that X-ray. Please get X-ray at the end of 10-15 days. So if patient says, sir, I got an X-ray of 15 days, don't accept it, because in Charcot, every 15 days you could get surprises. So always vouch for the fresh X-ray, fresh weight bearing X-ray in Charcot cases, and you would learn that it has progressed.
So in Charcot's, what is the role of angiography, whether it is MR angiography or CT angiography, to assess and decide your course of treatment?
Why don't go for MR angiography or any angiography? Why should you go? Yes, if you feel that the vascularity is a problem, then you subject that patient to the vascular surgeon's evaluation. He may need a CT angio or MR angio, that is his call. But very few Charcot I have seen with less vascularity. Otherwise, Charcots are hypervascular. You don't have problem of the vascularity in Charcot. You have a bounding pulses. So it is other diabetic foot which having ulcer, they may have lack of vascularity, and you want to know about the vascular status, you go ahead with uh, uh, angiography, MR or CT, but not with the Charcot.
Right, sir.
Okay,
Thank you.
chalo.
Sir,
So,
when is the next class, sir?
yes, so we'll have a next class on Tuesday.
So no class this Sunday, sir?
Now this Sunday I'm traveling. I'm traveling to meet my son. So no class on this Sunday. We'll be going ahead with Tuesday. And I'll
Okay,
just
sir.
drop down the title. I think we'll be discussing pilon fractures.
Yeah. No surgery, no live surgery tomorrow morning also, no, sir?
No, tomorrow morning. No live surgery. Next Saturday.
Next
We'll
Saturday. Yeah. Sure, sir. Thank you, sir.
Okay. Good night.
Thank you very much.
Sir,
Thank you
very
so much,
nice.
sir.
I think you're almost sleepy.
Good night, sir.
Yeah, because 11 is a 11:25 is a late night for me. Sorry.
Yeah.
So just to add, I've already started doing weight bearing exercise now in OPD, and that has helped a lot now.
Good. Yeah, that's
Thank
great.
you, sir. Good
Thank
night.
you, sir. Thank you. Good night.
Thank you.
Thank you
Thank
so
you.
much, sir. Good night, sir.
Good night,
Thank you, sir. Good night. Good night, sir.